Please.
بسم الله الرحمن الرحيم. برعاية كريمة من رئيس جامعة النهرين الأستاذ الدكتور علي عبد العزيز الشاوي، يقيم مركز الدنا العدلي للبحث والتدريب بالتعاون مع فريق العتبة العباسية حلقة نقاشية بعنوان Psychology and Pain، يلقيها علينا الدكتورة رضية علي بهاتي، أخصائية علم النفس العيادي، فتفضل مشكورة. تفضلي دكتورة.
Please, Dr. Razia, and if you can, please, a short introduction about yourself.
Okay, Assalamu alaikum everybody, and Bismillah ar-Rahman ar-Rahim. I'm a clinical psychology. I'm employed in the UK by a national pain management company called Connect Health. My role is to lead the psychology service. So we're a group of multidisciplinary professionals working. We have anaesthetists, we have physiotherapists, occupational therapists, well-being practitioners, psychologists, and nurses, and we work together to help help teach people who have been diagnosed with chronic pain to develop self-management techniques. So usually the people who come to us, they've had every test they possibly can. They've had all the as diagnostic processes that they needed, and there's really nothing more that the to manage the difficulties. So what I'm going to do is today, what I want to cover is just briefly look at the prevalence of chronic pain and depression and anxiety, look at the reasons for involving psychology with chronic pain patients, just touch on interaction between emotional functioning and pain, and through that we'll look at the biopsychosocial model of pain. But what I want to also add is that there's a spiritual element as well to treatment of chronic pain, and then talk about a culturally adapted ACT approach to pain management that myself and a colleague developed within our service, because we were finding that the services that we were providing to our general referral population, they weren't really suitable for patients from mainly the Pakistani Muslim background. So we sort of developed a culturally adapted approach for them. So we know that chronic pain affects between 1/3 and 1/2 of the population of the UK, which corresponds to just under 28 million adults, which is based on data, recent data from the best available published studies. Chronic pain is in the top 10 most burdensome health issues of our time, which means that it costs more than diabetes and cancer combined. So the burden on the National Health Service is huge, which is why a lot of pain management companies have been sort of springing up. Depression has strongly been linked with chronic pain. Between 20 to 50% of patients with chronic pain have comorbid depression, and those with severe pain are more likely to be depressed than not. Although it's likely that the etiology of pain is bidirectional, which means that chronic pain may cause mental health problems or may result from poor mental health, and that means that it isn't mental health that creates chronic pain, but mental health can actually exacerbate the pain experience. There's a high prevalence of health anxiety among chronic pain patients, leading to a poorer prognosis of recovery from chronic pain. Suicidal risk appears to be at least doubled in people with chronic pain, who are more likely to attempt and commit suicide. And this has been related to an exacerbation of psychological factors which are associated with suicidality. For example, depression, hopelessness, catastrophizations, insomnia, mental defeat, and a feeling of being trapped in their body that's never getting better. So including that, sleep problems are quite prevalent, which also then affect the levels of depression. So it is important to sort of look at managing sleep disorders as part of our chronic pain management services. I've already mentioned that. And so what is chronic pain? So pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or is described in terms of such damage. Whereas chronic pain is a pain with a duration of 3 months or greater that is often associated with functional, psychological, and social problems that can negatively impact a person's life. So it's not that the psychological and social problems have caused the pain. The pain may well have been caused by an injury or some other nociception factors, but what happens is that chronic pain can be perpetuated by other aspects of a person's life. And because of that, we need to be considering that in the 60s, the predominant pain theory was called the gate control theory, which talks about the spinal cord containing a type of neurological gate that blocks pain signals or allows them to pass to the brain. And what this theory says is that the gate is opened by the activity of pain signals which travel up small nerve fibers, and is closed by activity in larger fibers or by information coming from the brain. So the gate theory, control theory, emphasized the significant role that psychosocial factors potentially play in the perception of pain, such as negative states of mind, such as helplessness, hopelessness, anger, because they were found to amplify the intensity of the sensory input and led to sort of like the gate being opened. So in following this sort of pain gate control theory, the emphasis was on looking at ways of developing techniques to help people cope with stress reduction to help close the gate. And although this theory served well, what it didn't account for was phantom pain, quadriplegic pain, and post-surgery pain. So there was a need for sort of, further theoretical sort of views. And so the biopsychosocial model of pain, developed it by Butler and Mosley in 2000, that was considered to be a bit more of an inclusive pain sort of model, where we look at biological factors, look at psychological factors, and we also look at social factors that interplay and lead to pain experiences being either exacerbated or reduced. And this sort of became more of a predominant model and actually works really well, which is why having a multidisciplinary team is very important for offering a pain management service. But in my opinion, and in various other people's opinion, I think we also need to incorporate spirituality and develop a multidimensional model of chronic pain, which incorporates the biological, psychological, sociological, and spiritual factors. Because we know now from various research studies that the experience of pain is also impacted upon by a person's spirituality. So factors such as their faith, their spiritual experience, their higher levels of consciousness, their ideas of what the meaning of life is, they can also have a significant impact on how the pain experience is sort of manifested. So culture, conditions, circumstances, human interactions, they're part of the social dimension. Biochemical systems, cell systems, organ systems, physiological systems, fight or flight model, they all impact the biology. Our psychological dimension is cognition, perception, attitude, personality, behavior, health beliefs. So together, putting that together with the spiritual dimension, in my view, and various studies are showing now, recent studies, that this is becoming a more area of interest. So, often when I get referrals through our team for people to come to see me, one of the questions that people tend to ask is that, why have I been referred to a psychologist? I'm in pain, I'm not crazy. And this is sort of perpetuated actually by many people who've been through the health service, been from one department to another to find a diagnosis for and a meaning for the reason why they're suffering with chronic pain. And sometimes doctors actually do say, there's no pain, it's all in your head. So even if they don't say it overtly, there's often a suggestion that, get over it, it's all in your mind, it's not really there. So I think that can have quite a damaging effect on people. And when I see people, I often sort of explain to them that You're not here to see me because it's in your head. I believe that you are in pain. It's that psychology can help. We use our knowledge of psychology and health to promote general well-being and help you understand your physical illness. And then I explain to them that we use a biopsychosocial perspective to help them develop various skills to be able to manage the distress and disability, but also develop their spirituality if that's relevant to them. Not everybody is spiritual, we have to understand, but for many people it is important. And so part of the psychologist's role is psychoeducation for both the patient, the family, to understand the connection between the pain and the emotional functioning. We help them identify relationships between behaviors, thoughts, mood, and how that might impact pain. And I always take quite a long time in my first couple of sessions to explain the neuroscience of pain and distress, how the fight or flight response is triggered every time a person feels pain, and how the brain is fooled into thinking a perceived danger is a real danger, and how that might maintain and exacerbate the pain experience. And I found that when I actually explain the neuroscience of pain and distress quite in a simple and understandable way, people are more likely to engage in sort of activities which are especially related to reducing the fight or flight response and triggering off the parasympathetic nervous system. So they're more likely to abide by what you're explaining to them and telling them if they know why you're telling them that. So that I think is really important. And then we assist in helping them learn new skills to address depression, anxiety, stress management, sleep hygiene. One of the things that we don't do in our pain management company, and many pain management services sort of are the same, is that we are not a mental health service. So our role is very much looking at the pain psychology and looking at how pain psychology can help. And of course, mental health and physical health do go hand in hand. We can't say, oh, we're not working on your depression because that's not a physical health. If the depression is related to their lifestyle changes and the impact of the chronic pain, of course we work with that. But if somebody is experiencing, for example, historical PTSD or ongoing psychotic experiences, then we wouldn't really work with those people. But those people who are struggling to manage their life because of the pain and the change in their life because of the functional difficulties, we actually work very hard with them. We assist in identifying and making recommendations for individuals with high risk factors for opiate use. And now, as I mentioned earlier, there's a huge drive to help people come off opiates because of the really lack of efficacy. The NICE guidelines in the UK are really pushing for that. And so it's really helpful to try and get people on board who, one, are willing to reduce their opiate use and willing to learn self-management techniques. So that's an important aspect of our pain management service. And then we teach specific strategies for fears related to procedures. So a lot of people are actually very frightened of coming off medication because of the fear of the pain increasing. So sometimes we may need to sort of like do some operant type of conditioning, behavioral type of methods. We identify and refer for specific treatments if necessary. Some people might need psychiatric care, and in that case we might not see them, but we signpost them to whoever they need to, or sleep specialists if their sleep is really, really detrimental to their physical and mental health. And of course, as I said to you before, we work in a holistic manner. We have a multidisciplinary team, and we work together to try and provide a program which is going to be beneficial using a comprehensive biopsychosocial spiritual approach. Identifying and making recommendations with, I think I mentioned that already. This is what I was saying. I was rushing through these slides and maybe put some repetitive stuff in. Yeah. So one of the things I already mentioned is this neuroscience of pain, that, you know, attention to pain is linked to activation of the fight or flight stress response and action. I'm not going to go into great detail about that, but basically people who are in pain are very often in a state of constant hypervigilance, which amplifies their responses, which results in an abnormal focus on their pain, and they become quite preoccupied with, you know, even the slightest signal, and this stops them from doing activities which would actually be beneficial for them. So, for example, they avoid movement because they're frightened of triggering off the pain response. But being in a state of hypervigilance all the time is really not very good for them. So when they're in pain, the anxiety that pain is signaling tissue damage and harm rises. The brain becomes more focused on the problem. Change takes place in the nervous system. Then that leads to more pain, more anxiety. So it becomes a bit of a vicious cycle. So that's why this is one of the reasons why I spend quite a bit of time at the beginning of my work with my patients, is to help them understand the neuroscience of pain. So the evidence base is that a recent draft consultation by the NICE, National Institute of whatever that stands for, National Institute, can anybody help me?
Clinical excellence.
Clinical expertise, yes. I normally write I hate acronyms, but yes, that's the one. It was a recent draft consultation, but it's actually now been released, that CBT has been shown to have a positive impact on pain intensity, pain-related interference, health-related quality of life, and depression among individuals with chronic pain. But it also showed that acceptance and commitment therapy, which is a third wave CBT approach, that also improved quality of life and sleep and reduced pain and psychological distress, and was also cost effective. And one of the gold standards of pain management services is having sending everybody on what we call a pain management program, which is a group therapeutic program, usually over 8 weeks, usually around 30 hours max. And that incorporates ACT, and the NICE guidelines actually recognize that as well. So just sort of, I'm sure a lot of you know this, but some key concepts for CBT for chronic pain. It reduces perception of pain and psychological distress, improves physical and role functioning by helping decrease maladaptive behaviors. It increases adaptive behaviors, identifies and corrects maladaptive thoughts and beliefs, increases self-efficacy for pain management, increases skill acquisition. And the techniques that we use is relaxation training, guidance in activity pacing, goal setting, behavioral activation, problem solving training, cognitive restructuring, and helping people learn ways to control their experience so that they don't feel at the mercy of their pain. And so a lot of our pain management programs incorporate both CBT and ACT actually, but a lot of our clinicians do ACT or CBT on a one-to-one basis as well. On the other hand, acceptance and commitment therapy based approaches, which are frequently identified as third wave cognitive behavioral therapies, they emphasize the importance of facilitating the client's progress towards attaining a more valued and fulfilling life by what we call increasing psychological flexibility, rather than trying to change cognitions and sort of like move away from distress. So you might wonder, well, what is the difference between the two? So ACT as the third wave approach of CBT is more about how you think about pain and emotions, whereas CBT is what you think about emotions. So we in CBT, we get people to change what they think about themselves. And with ACT, we look at how people are thinking about their pain and emotions. And staying with the emotions is part of ACT, while for CBT, it's changing the emotions. So that is sort of like a very crude difference between the two. ACT emphasizes the importance of developing psychological flexibility by not moving away from the distress, by not pushing the distress away, but by staying with it. So staying with the emotion and learning to live with difficulties. And an important component about in acceptance therapy is acceptance itself. So what I'm going to talk about next is really about how we have used, really not very good at this. So how we use ACT to work with our patients. So there are 6 processes of ACT, and these 6 processes are acceptance, cognitive diffusion, contact with the present moment, self as context, values, committed action. And the purpose of these 6 processes is really to develop psychological flexibility. And I think sometimes people actually get put off by the terminology used in ACT, like cognitive diffusion, self as context. But when you actually start practicing ACT and start looking at the processes, it's not really that hard to understand, and it's quite easy to apply to oneself. So I'm going to go through that and talk about that a little bit before I talk about how we can apply it to ourselves in sort of a more spiritual manner. So I'm going to sort of just show you this hexaflex was developed by the people who are the pioneers of ACT, and there's 3 components within this hexaflex. So this part, I don't know if you can see my mouse moving cursor. Yeah, oops. I'm gonna have to go back again. So I really don't know how to get back without going to this. So this part on the left, it's this is the acceptance work that we do. This in the middle is the mindfulness work, and this on the right, these 2 parts, that's really looking at how we can move towards our values and make a committed action to take us towards our values. So these are the 3 sort of strands of the hexaflex that are connected to the 6 processes. So if we look at the processes, so acceptance is when we develop a state where we are willing to accept our thoughts and feelings, even when we don't like them. And in terms of pain, we're talking about, I have my pain and I have to live with it, and it is what it is. So it's almost taking a stoic approach, a philosophical stoic approach, that this is my life and I either fight against it or I live with it. And since I can't fight against it, I need to live with it. So that's when if you move, if it's high, then that's how you feel. But if it's on a lower sort of level, if you come down here, then you're constantly struggling with your thoughts and feelings and struggling to come to terms with that pain and that distress that you're experiencing. And then at the bottom is what we call the diffusion, and it's actually a state. So if we're struggling, we're in a state of what we call cognitive fusion, where our thoughts are really, really, enmeshed, and they really don't know how to sort of cope with the situation, and the thoughts are coming through your head like if you think about it like a radio broadcast, they're like a stream or a river, like a radio broadcast that never seems to end. But if your diffusion scale is high, then you are looking at each of your thoughts as just one of many ways to think about things, and you know that whatever you decide to take on board, it's up to you. You can do what you want with those thoughts, that you don't have to believe those thoughts. You don't have to be your thoughts, right? Then there's this attention to the present. So this bit is the mindfulness, and I'm sure you've all come across mindfulness, the buzzword, that it's almost like a panacea for everything that goes wrong in your life, but it's actually quite important. So it's being able to pay attention to what is happening in the present moment. But if you are in a state of psychological inflexibility, you might spend a lot of your time traveling. So either you're lost in the past, thinking about the things that happened in the past. Why did this happen? I should have, I could have, I shouldn't have done this. Or you're worrying about the future, about what if this happens, what if that happens, and you're trying to cross bridges that you've not even reached. And while you're doing that, you're actually missing all the glory and beauty of the present moment. And the present moment might not be as bad as you think, right? And then this bit, this is the bit that I think is probably the hard bit. Self as observer, self as context, it's often referred to, because this is the bit which talks about how you look at yourself in the context of your situation. So it's like self as context, it can be like a negative story about yourself. The person I call me is my thoughts and feelings about myself, is when you're sort of like in a good place. But when you're not in a good place, you're saying the person I call me knows what I am thinking and feeling, but it's not a safe place. It's a negative story about yourself. So you take the context out of your life and you just become your thoughts and feelings. So it's a little bit difficult to explain, but if we think of thoughts and feelings and sensations as becoming you rather than you becoming the observer of your thoughts and feelings and situation, that's the place we want to be, is to know that this person I call me is my thoughts and feelings about myself. Sorry, that this person I call me is not my thoughts and feelings. I am distinct from them. So when I say to myself, I am a mother, I am a sister, I am a professional, that's me. But then if I say, but I'm a loser, I'm pathetic, everything I touch goes wrong, then I might become that. So it's like, yeah, in that situation, I perhaps didn't behave in a way I should have, but I can learn from that. So then that way you become an observer. I did wrong, but I can change that because I'm also a mother and I'm a professional, and there's an aspect of me that's good. So it's looking at yourself as being in context of your situation. I hope that makes sense to people. And then we go to the last strand, the third strand, where if you're in a good position, you're clear about what you choose to value in your life. So in the context of pain, what we find often is that people, because of their lack of functionality, they move away from their values. So values could be things like, I enjoyed going for walks, I enjoyed socializing, I enjoyed meeting up with family. I'm a family man. My values are very family orientated. But because of my pain, I no longer meet with my family. I no longer go out for walks. I no longer want to sit with the people my friends. So that's moving away from the values that you always took for granted. So when you sort of like develop psychological flexibility, you're able to then say, okay, I can't go for long walks anymore. But what I can do is I can sit in the garden, I can sort of do a potter around in the garden. So you look at what your values are, decide what's important to you, and then you move towards values that you can still do, but you've been avoiding because of the pain, right? So that's that bit. And the committed action is almost like the values is what you want to move towards. The action is what goals do you set to meet those, to actually follow the values. How do you see yourself moving towards those values? How do you get there? So I guess the values is like your intention, and the goals is sort of like planning out your journey, how you're going to get to that intention. And that's the bit where we are committing to an action. Hope that wasn't too complicated. So again, you know, this is a bit more, maybe a bit more easier to understand. Contact with the present moment is learning to observe thoughts, feelings, behaviors, and sensations so as to act effectively in the present moment. Self as context is being able to recognize thoughts and feelings while knowing that you are distinct from them, and therefore you are part of the bigger picture. You know, you are not a loser because you lost out on something in your life. If you don't no longer work because of your pain, that doesn't mean that you are a failure. In the context of the wider, you're also might be a loving father, a loving husband. So there's a bigger context to your life. Acceptance is letting go of the need to control, being willing to experience all thoughts, feelings, and sensations as they happen in your life. Diffusion is recognizing thoughts, feelings, memories, sensations just for what they are. So you reduce the influence they have on your behavior, since getting entangled with them will only cause more confusion. And then values, being clear about values and using them to influence your life direction. What do I want? What values do I want to move towards? I want to be a person that might want to leave a legacy behind. And how do I get there? And then making committed actions to follow those values. So these 6 processes of ACT increase our psychological resilience to chronic physical health conditions by increasing our psychological flexibility. And people experiencing difficulties in adapting to changes in their life caused by pain can use these 6 processes to try and do that. So again, psychological flexibility is the ability to be present in the moment with full awareness, be open to whatever experience occurs with a willingness to be guided by core values or whatever action is taken. And it's a very value-based approach, and that's why I think it resonates very much with the Islamic our Islamic teachings, because from the Muslims in our community, because of our religious belief systems, our religion is a way of life. Our belief system is a guiding point to living a value-based life. And I think that's why ACT is probably congruent in managing pain conditions, because it's all about values and learning to move towards what we believe in. So if we look at acceptance in a bit more details, I think it's important to look at acceptance isn't giving up and saying, oh, this is my life, this is what I'm doomed to have to live with. It's not resigning to pain, but it's the individual, sort of like the unsuccessful attempts to avoid or control pain is, you let go of that. So, you no longer try to control what is not controllable. It's like life happens, and some parts, in fact, the pandemic is a really good example. When the pandemic happened, a lot of people were in a state of flux and state of emotional distress, but it was, and it is what it is. You can't change it. So actually fighting against it is only going to increase distress. So acceptance is the opposite of experiential avoidance, in the sense that it doesn't mean that you're closing your eyes to reality and pretending that it's not there, trying to get away from unpleasant thoughts, feelings, and memories. But instead, it's a willingness to face the experience and learn to live with the discomfort. So even when you're in pain, you notice that you're in pain and you don't fight it and you just let it be. So it sounds quite radical, but learning to tolerate the unpleasant stimulus without struggling against it makes a big difference in how high the pain, the sort of the intensity of the pain experience. So, for example, pain patients are given methods that encourage them to let go of the struggle with pain in order to help them develop useful coping strategies. And these might be things like mindfulness, for example. It could also be, doing some deep breathing and just focusing on the breathing and letting the pain stay as it is. It enables focus on other experience or aspects of the environment. I often do grounding techniques with people, get them to ground themselves mentally, so that they're not trying to change the pain, but they're just focusing on something else. McCracken, one of the leading pain sort of researchers, says that pain-related acceptance leads to enhanced emotional and physical functioning in chronic pain patients, above and beyond the influence of depression, pain intensity, and coping, which is saying a lot. And from an Islamic point of view, if we look at the importance of sabr, patience, endurance in times of difficulty, this concept inspires individuals to strive for a meaningful life and helps us develop acceptance of the affliction instead of struggling with aversive situations. And again, sabr doesn't mean, suffer. It means, tolerate. It means sort of like live with the situation in a more, in a way that it doesn't take over your life. The focus on long-term consequences rather than immediate positive consequences, such as avoidance of aversive situation, which a lot of pain patients do. They will avoid doing things because they think the pain will become aggravated. this enables acceptance and commitment to change. Our Islamic teachings discourage avoidance of committed actions related to values when faced with aversive situations. So the hadith, trust in Allah, but also tether your camel, reflects the idea that patients should act and engage in self-management rather than take the fatalistic view of relying on God alone to provide solutions. That's like saying, God is punishing me for whatever I'm doing. I've got to suffer my fate. And then one of the things that we actually found is that a lot of Muslim patients were holding the myths that there's nothing they can do. If it's God's will for them to suffer, they just have to suffer. But, again, Allah says that, trust in me, but also, well, the Prophet, peace be upon him, said, trust in Allah, but also tether your camel. So this hadith is helpful in motivating patients to engage in self-management of pain rather than viewing their fate as assured and for them to have to suffer. So where cognitive diffusion is concerned, this is when one becomes caught up in thinking and allows the thought to dominate behavior. And this is quite common in a lot of our pain patients, where they find it difficult to step back and detach themselves from their thoughts, images, and memories. But if they make closer contact with verbal events as they really are, not merely as what they say they are, they're more likely to diffuse. So, for example, walking into a room, the metaphor I always use with patients, and it's quite a useful one, is that if you walk into a room with spider webs and you really hate spiders, and it's very uncomfortable and distressing, you might try to your best to ignore the spider webs, but it doesn't stop the discomfort that they give rise to. So when you walk into a room like that, you disentangle yourself from the spider webs. And whenever you notice yourself getting caught in one, you practice diffusion by disentangling yourself. But it doesn't mean the distress has gone away. It just means that you're willing to sit with the distress and discomfort, but moving away from the thoughts that enmesh you with that. And it does seem to sort of like help people, diffuse a little bit from the thought that pain is all they need to think about. They accept that the pain is there, but then they move on and think about something else, almost like disentangling from them, and sit with that process of, we know the pain is there, but we don't have to just think about pain. And cognitive fusion also resonates with the concept of vasavasa, the repetitive fears, doubts, or whispers that we talk about within, the Islamic thinking. And we often use I don't know if people are familiar with this. It's a lovely poem called The Guest House by Jalaluddin Rumi, which is quite helpful in creating diffusion. I haven't actually put it up here today, but people can actually Google it, and it's basically saying that whatever comes in your life, just accept it and think of it as an unwelcome visitor, because sometimes bad things happen, but they happen for a good reason. And this is sort of echoed in the Holy Quran, where there's a verse that says, but perhaps you hate a thing and it is good for you, and perhaps you love a thing and it is bad for you, and Allah knows why you know not, because it helps take perspective of thoughts, metacognitions, and behaviors. Because sometimes we think something bad has happened to us and we are really resentful and aggrieved about why this bad thing has happened, but sometimes in Allah's wisdom, He knows why that's happened, and it's better for us because it may save us from something else. And it's having that, faith in these things, and help. This would help us move towards value-based life rather than trying to change things. The Holy Quran recommends contemplation and remembrance instead of trying to fight unhelpful thoughts by engaging them or trying to conquer them. So when the mind is allowed space and silence, then any thought entering the mind can be seen for what it is, just a thought to be observed and understood, rather than the defining factor of an individual's sense of self. And a lot of the time, chronic pain patients become the thought. So if they think that they're useless because they have chronic pain, they actually begin to believe that they are useless. They don't see any other use of their life, and then they become a victim in their state. So it's about noticing thoughts and saying, I am not my thoughts are not facts. I am just a thought. So ACT also promotes ongoing non-judgmental contact with psychological and environmental events as they occur, with the aim of experience the world more directly, be it good or bad. So again, it's resonates with Islam in the sense that, you know, life is not a smooth run. We are tested in our life. We're going to be constantly tested by the things like Allah says that we're going to be tested by our wealth, our health, with our loved ones, with family. And from an Islamic perspective, using muraqabah meditation, which muraqabah metaphorically means meditation, enables the individual to watch and take care of their soul and gain a closeness to their creator in times of need. So this is where mindfulness and being present in the moment without attachment to the past and future is really important in Islam, because one of the things that a lot of our chronic pain patients seem to reflect is that because of their past sins and things they've done in the past, they might be being punished and they're suffering. But we have the concept of tawbah, we're referring to repentance or returning to the right path, which helps us, sort of put that past behind us and focus on fulfilling our pledge to God to change our ways and, you know, be a better person and to move towards a value-based existence. And the Quranic verse repeatedly referred to in the Quran, we burden not any person but that which he can bear. And Allah does not charge a soul except when with that within its capacity. These are really useful to help motivate individuals who might be really struggling with their life situation to practice prayer as a way of developing a state of being present, to understand that they would not be suffering as much as they were if they weren't, their soul weren't able to bear it. So mindfulness in this context is about becoming aware of thoughts rather than suppressing them, and learning them to pass rather than becoming overwhelmed by them. And again, going back to the self as context, we're talking about humans as being more than just thoughts and feelings. If we become enmeshed in the context of our lives, we can find it difficult to step back and observe. So it's trying to, you know, look at the negative self-story. And I've already said, we hold stories like I'm a professional, I'm a brother, I'm a sister, I'm active. And then if we start identify with every story in a negative way, like I'm boring, I'm useless, I'm pathetic, we then are not our thoughts, but we are consciously experiencing them. So it's about standing back and thinking, this is my thought and I am experiencing it, but I am not the thought. And moving back and looking at the context of your life rather than the context of that particular situation, and moving away from being closed down by those thoughts. So again, tawbah, repentance is a process that allows the nafs to connect with a sense of self. It's a safe and reliable position from which to observe and accept all shifting in experience. So even if you feel that you have a negative story about doing wrong in the past, you know, it's something that in our religious context we can change. And through that we can focus on behavior change. There's no need to remain attached to these self stories, even if they were linked to unacceptable past actions. I mean, one of the things that our religion tells us is that even if you've done wrong, it's important to not speak about that wrong. If you have repented, you know, that is between you and God. You don't have to tell people about the wrongs you have done. And also it's about making the effort to make the changes yourself. So indeed, Allah will not change the condition of a people until they change what is in themselves. So what tawbah does is allows patients who are struggling with the pain condition as being a punishment for past sins to be able to let go of such conditions, or let go of the tug of war that often occurs between the thought and the distress that it may cause, and giving yourself space and silence, and just defining your individual sense of self. So moving on from that, it's really important to think about values. Persistent chronic pain conditions often lead to patients chasing limited methods of alleviation. So you might neglect socialization, exercise, friends and community, intimacy with partners, community events, prayer and practice of faith, because there's a fear that the chronic pain will be exacerbated, it will be sort of aggravated. But a values-based life means patients can take actions to pursue their values and bring some meaning back to their life. I mean, even some simple things like a lot of my patients who, non-Muslim patients, say things like, I used to enjoy art. So we talk about, social prescribing. Why not join an art group where you can start, making things? And simple things like that can start to begin for them to notice what their other values are and what they can bring into their life. ACT advocates purposive action as a way of exploring what is more important to an individual, and it can help. So values can be a compass to make the right choice and decisions. So for us, from an Islamic point of view, we have a moral compass in our teachings, in our Islamic faith, and that can help us decide what choices and decisions we can make about our life. So for example, if somebody is a chronic pain patient, they've lost their livelihood. If they have a choice of making illicit means of money and not, their religious values give them a choice. That are they going to choose the easy way out and make, sort of money through, I don't know, drug dealing or something like that? Or are they going to look at money is something that I'm going to have to live without, but what other things can I do that are going to fulfill my life and make my family happy as well? So we make choices and decisions based on our faith and our values, and remembering that our life is temporary and fragile is a really, I mean, it might seem sort of radical, but again, it's important for us. It's important for us as Muslims, but it's also important generally because for Muslim in particular, we want to make our afterlife better. We know that this world is temporary. The next life is the more important one. And every action and behavior is going to be judged on the day of judgment. So if we act according to values and we leave a legacy behind in our life, that will be something that will follow us. Our deeds will follow us in the next life, and it will be foundations for the positive legacy, as well as, helping us know that we are going to go in a happy state. So this is a really useful way of getting people from the Muslim faith to sort of like reevaluate their life and look at, am I going to be the victim here, or am I going to sort of like pursue my values and start doing the things that I can still do, even in a state of ill health, that are going to benefit me and leave a legacy behind. And I think it's a useful way of, tapping into eliciting some change in a person's life. And finally, the sixth sort of process, the committed action, refers to being able to live an effective and mindful life which is congruent with one's values, while accepting the pain and suffering that's an inevitable part of life. The Holy Quran emphasizes the importance of taking action, committed action, even when one is inclined towards acting towards avoiding pain. So again, that's the verse that keeps coming up in the Quran: Allah does not burden a soul beyond that it can bear. It's a reminder of us that, remember Allah, practice mindfulness and meditation as a way towards deciding what your values are, what things you need to do, how you need to make your goals, how you need to establish goals, how you're going to get to that journey towards meeting your needs and following your values. And this was actually, it's a really useful way, because a lot of our patients were often avoiding aversive situations and acting in a way that were leading to a lot of avoidance behavior. So like they wouldn't do exercise, they wouldn't sometimes, like things like, even we were talking about pacing, how it's important to pace yourself. So exercise is important, but you can pace yourself. So do 10 minutes of exercise and rest. But there was either one end of the spectrum or the other. So either they were not doing anything and they were asking or relying on family members to even like go and get me a glass of water. So not even going to the kitchen to pick up a glass of water, or they were being martyrs and overdoing what they didn't need to do. So like, particularly in women, even when they knew that they were struggling with pain, they would still do the cooking and the cleaning and refuse to delegate. So we talked a lot about how are you going to reach your goals and values if you stay in this state where you're either aversive to a situation or you're not taking the right action to reduce the the pain and suffering that you're experiencing. So it was a very useful way of getting into that conversation and getting people to evaluate how they were acting in their life, what sort of actions they were taking to help them manage their pain better, whether it was over exerting themselves or completely avoiding situations that were actually good for them. So following moral and social behavioral principles is seen as an aspect of committed actions. Working towards values and actual actions in a paced and graded manner is also mentioned in the Holy Quran as well. It's anything that you do, you implement gradually and in a graded manner, not throw it on them. And the example we often give to people when we're talking about this is that we talk about the story where when the alcohol was forbidden, and it wasn't forbidden in one huge sweep. It wasn't said, right, that's it, no alcohol. There was a graded manner in which it was sort of reduced and then forbidden. And we talk about how it's important that any changes that you make, you do in a graded manner, in a paced manner, so that it is easier for you. And that applies also to opiate reduction as well, reduction of medication, that it can't be suddenly stopped. It has to be done in a medically approved manner, in a way that they are replacing the benefits of any medication that they're taking with some other activities that help with the pain management. ACT does not view the absence of sadness as a normal state, but instead that pain, difficulties and unpleasant experiences are inevitable and natural consequences of life. And that actually fits in very well with our Islamic perspective, that life is not, in life we don't have an absent state of sadness. We have sadness, and that's normal. And there's lots of stories that we use from the Quran and the Hadith about even our prophets, peace be upon them, to having sort of life histories where they experience huge sadness and deaths and tragedies, and how life is not all about bed of roses. So I think that helps as well for people to put in context what's happening, and how they can contextualize their life and look at it from a different perspective. And that's it. There's some references there for people if they want to follow things up. I'll just stop sharing. I hope that was clear and not too fast and not too chaotic for you.
It was really great lecture and presentation. Zubair, if you have a comment.
Sure, alhamdulillah. Thank you so much, Dr. Razia. That was really insightful. I think one of the biggest, I guess, value we've gained from this lecture, because most of the teachings we've had has focused on CBT. Yeah. So this has been so interesting, taking the ACT approach and looking at it from a very different angle as well. I was just wondering if you could just shine some light on this. With ACT, it sounds like accepting a lot of the internal processes.
Yeah.
Is there an element of accepting external? Because often we get a lot of clients, the Iraqi clients, and unfortunately very difficult situations. There's a lot of family issues. There might be some abuse, some violence going on as well. How do you work with ACT in the external sense, with external situations?
It's actually exactly the same, because because external events create internal events, don't they? Yeah. Experiences. So anything external that happens. So like, for example, we're talking about chronic pain, and say somebody who's had a car accident, and as a result of the car accident, they have developed disability and pain. That is an external event, but the external event has created internal sensations and emotions and distress. So when I was sort of mainly talking about how we manage the internal, but it's all sort of part and parcel of the same thing, that you have to acknowledge what the external events were and how they've reached the stage they are. I was talking to a lady the other day who she had bariatric surgery, And as a result of her bariatric surgery, she nearly died. She got septicemia. She went into a coma. Since then, she has lost a lot of functions in her body, and she's in chronic pain. So you can't sort of separate the external event that led to her experiencing the pain and the suffering. So within ACT, it's also, so when we, again, if you go back to the acceptance level, sabr and acceptance isn't mean saying it's okay if that happened to me, resigning to it. It's not like accepting it in a really happy way and saying that, well, it is, you do say it is what it is. I mean, I think that stoic approach is still very important, but it's a case of looking at it in a way, I can't change what happened. It happened, it shouldn't have happened. But what it has done, it has created something inside me that I am struggling with. So that's why looking at the internal processes is really important, because we are trying to change the struggle and letting go of the external event. And it doesn't mean that you sort of like, so if I give an example of like domestic violence, if somebody is experiencing domestic violence, you don't say to them, it's okay, just focus on your inside, what's happening inside you, and do sabr and you'll be fine. You still look at, you know, how are you going to move towards your values? Is this acceptable? Is it acceptable for you to be experiencing domestic violence? Is it acceptable for a man to do this to you? No, it isn't. So now you need to take action to remove yourself from that situation, but also work with the feelings inside. And say in Iraq, you know, there's so much pain and suffering has happened because of the external events. If you are in danger, you don't sit there and just work with internal experience. You do still, your sabr is more about learning to accept what's happened, but you still remove yourself from that situation if you can. If you can't, then you work with the internal feelings, because it's not the event that's the problem, it's how we react to it. Because the same event could have a lesser effect on one person and more of an effect on another. But global events like war, terror, torture, oppression, there's something completely different about them. So you cannot separate the external from the internal. They're just sort of like so enmeshed together. So I would say that you work with both by looking at accepting that you're in a situation where you can't really get out of this situation, but what you can do is try to temper your reaction to it and manage that so that the distress is less, and try to get some more things going on in your life which make you feel happier. But at the same time, it doesn't mean you forget what's going on out there, and you have that, oh, I'm having sabr, I trust in Allah, it'll all be fine, because you know it's not going to be fine. And but if you look at it as, this is Allah's test on me, I'm going to suffer it and I'm going to try and manage it. But eventually, if Allah wills, my situation will change. So that's where faith can come in as well. I hope that answers your question.
Yeah.
No, that's really useful. Thank you.
Yeah, like what I understand from you, like to divide the factors into what we can't control, so to accept it, what we control, try to focus on it and do. Yeah. I have a question before, like then I will share for Dr. Zainab. Comparing like ACT and CBT, is there any studies or opinions to like compare what their effect and which one more preferent or better or have more advantage, or what do you think?
I think that the studies that, especially the NICE review, that looked at studies in CBT and ACT. And if you I'm talking about pain at the moment, and they were more or less comparable. There's a CBT yielded good results, but so did ACT. But for me, I think ACT is more congruent with Islamic communities. I personally think ACT, because I've been trained in CBT and my grounding was in CBT, and over the years I've found that CBT isn't always helpful for Muslim patients. Like when you're trying to apply this particular model, and I tend to work more integrative, to be quite honest. I'm more integrative in my approach. But since learning ACT, I've found that it really does fit in with the Islamic model of psychology. And there are studies on depression and anxiety that actually show CBT is very effective, but they also show that ACT is very effective. So I don't think they're saying that one is more effective than the other, but they're both very effective. So I think we can use whichever studies, whichever sort of approach we think is going to fit with that particular patient. If you're trained in both, I think the good thing about that is that you can tailor it according to your patient needs.
Yeah.
Does that make sense?
Yeah, very clear, very clear. Thanks a lot. Dr. Zainab, please.
Thank you, Dr. Abdullah. Thank you. Thank you, Dr. Razia. Thank you for the great information and the great presentation. What I appreciate from this lecture and this presentation the most is the clinical approach. Frankly, that's what we need, is the clinical approach. So from this point of view, let me put the spotlight on, at first, we almost always struggle with the psychomotor retardation that keeps the patient with the disability, with the chronic pain, from seeking help. This psychomotor retardation makes them feel that they are incapable and they are unable to move on. From your clinical point of view, how do you make them to engage? How do you put them up with the clinical approach? How do you overcome this psychomotor retardation? Frankly, this step is a huge step in Iraqi culture, and we face it on a daily basis. Can you give me your perspective of this point?
So one of the things that I found with chronic pain patients is they are very difficult, in the sense that sometimes they get stuck into, just like you're saying, into that state where they cannot see anything better for them. So if they're in a state of pain all the time, there's in a state of disability, they can't see a way forward. This is my personal approach. I'm not sure about everybody else, because everybody works in their own way, but my personal approach is what I touched upon, that I explain first and foremost what my role as a psychologist is, because these type of patients, I always say, why am I being sent to a psychologist? Why am I not being sent to a physician?
Physical therapist,
physician or a physiotherapist. Why am I seeing you? What are you going to do for me? So the first thing I always explain to patients, so it's psychoeducation. My role is this. This is how I help people, and then I give them evidence that I say that research shows that, the way we process our emotions when we're in pain, that affects the pain. It makes it worse. And if we can manage our emotions, we can also reduce the pain experience and intensity. So I give them a bit of psychoeducation. But then, as I said to you earlier, the neuroscience seems to work magically, because I always start off by saying, I'm going to give you a couple of exercises to start doing before we do anything further. Because when you talk about the neuroscience of the fight or flight response, because like I say, pain patients are in a constant state of fight or flight. They're in a state of hypervigilance, because they're experiencing central sensitization of their neurotransmitters that send the pain messages. They're constantly expecting to be in pain. They're constantly expecting to hurt. So because of that, they're in a state of hypervigilance. So my first step is to reduce their anxiety and reduce their hypervigilance. And what I do is I teach them deep breathing first and foremost, so it's abdominal breathing. And I explain to them that when you do abdominal breathing, what you do is you push against your vagus nerve, you push against your internal organs, and you trigger off a relaxation response. And when you trigger that relaxation response, the pain will start feeling a bit more under your control. And the people who listen, and when they do practice it, it makes a huge difference. After a couple of weeks, they come back and they say, oh, that really worked. I really felt better doing that. And so I do deep breathing. Then I also do a progressive muscle relaxation technique with them. And I ask them I send them a web link and I ask them to practice it every single day. So for two weeks, normally I get them to do that. When they do that and they've got some physiological control over their body, then that actually introduces their willingness to sort of listen to what other approaches might help with their pain management. And then I give them a bit of psychoeducation about how pacing is really important. That one of the things that chronic pain patients often do is if they have a good day, they really push themselves and they do so much that the next day they're in bed for a couple of days because they've overdone it. So I talk about the physiology again, about and I also give them education about how they can change that, and then move on to sort of like talking about how negative thoughts, or in ACT we say unhelpful thoughts, can influence the mind and the body, and give them a bit of psychoeducation, and then give them exercises. So what I found is that if I keep giving them psychoeducation before I move them on to the techniques, they're more likely to engage. Because one of the mistakes I think a lot of people make is they just launch into, right, you can't do pacing. What I need you to do is I need you to do deep breathing, but don't explain why the deep breathing works and why it's important. And a lot of people just don't bother doing it.
Yeah, thank you. Great information, thank you.
Other colleagues, if you have any comments, question. Minute of silence.
I think we've exhausted everybody.
It's really like very valuable and deep topic, like need to be digested, to be like consumed. Then with the time, I think many questions. Even like for me, I think this modality itself, the biopsychosocial and even the spiritual aspect, can be applied not just in the Islamic community. All other communities just need some understanding for other communities, for the Christian, for other other religions. Just
absolutely
understand it, then it will go through the understanding of the client themselves. So yeah, Dr. Zainab, please.
Hi, Assalamu alaikum. Hi, just a question, reflection on opiate dependent individuals who are on and off. So I have a patient who has got a physical neurological condition that causes pain, but actually I think 90% of his pain is probably hyperalgesia to do with the opiate dependency. He's on an enormous amount of opiates, officially and unofficially, and he just can't come off them. And he's terrified of pain. When he withdraws, it's psychological as well as physical pain and shaking and all the kind of dependency type of scenario. He says he's religious and spiritual, but the problem is he's incredibly impulsive. He's got ADHD. He's very dysregulated. He might, accept all these sort of philosophies about acceptance, etc. But he's too impulsive to sit with that, and then it'll go out of the window. He'll accept it logically, but he just can't sit with any pain or dysregulation. That's his problem. So with cases like this, I mean, do you still go down the route of pain management, or do you maybe start with other regulation type of approaches first?
I would definitely start with emotional regulation methods with this person, and get them in a state where they start feeling more in control of their emotions and control of impulses as well. Because I'm trained in dialectical behavior therapy, and that's all about emotional regulation. And that's why I was saying that I tend to try to be integrative if I can. And somebody like that, I would use a lot of emotional regulation work first and foremost. And when I feel that they're in a state that they're ready to sort of like try, obviously you have to get them to be motivated to come off the opiates as well. Some people are being pushed by their physicians and GPs because they've got no choice. They're saying that you're going to have to, because we're just going to stop them. So some people are forced into it, but some people actually can be persuaded to come off them. So emotional regulation first, then I would sort of like draw up a plan to sort of reduce the opiates and get them to also do the sort of self-management of pain.
Sure, thank you. I think one of his difficulties is the chicken and egg, because he can't be put on stimulants for the ADHD because of his substance misuse. He can't be trusted.
Oh,
He might,
right. So is he receiving any help for substance misuse?
He's received various support methods for it. Nothing sticks really. He'll just stick with it for 2 hours and then get dysregulated. He's very impulsive. He's very restless, agitated as well. He's got a neurological. He's actually paralyzed, so it doesn't help either. He can't release the agitation physically. So I think that adds to his kind of physical tension, and it just melts into the physical pain and the psychological pain. He's a bit of a mess, to be honest, and I think we all empathize with how difficult life is for him. But the problem is because his opiate dependency stops him from being prescribed stimulants to get rid of the agitation and restlessness. When he is agitated and restless, he can't use cognitive strategy. So everything is just obstructed by his substance misuse at the moment.
I think that's a really difficult one because, like you say, it is a bit of a chicken and egg situation. But if he was willing to sort of like take on board that if he wants to reduce his impulsiveness and the agitation and everything, he needs to come off the opiates. And if he needs to come off the opiates, he needs to do some work on that. It sounds like a motivational interviewing sort of scenario with this guy, but like you say, he's got he's got neurological issues as well, so I think it can be really difficult. I have come across people like that, and all I've done is to just give them some self-soothing techniques, some emotional regulation techniques, and the best I can, and then sort of like not always gone ahead with the full work because they just can't engage.
Yeah, thank you. It's reassuring to know I've not missed anything in a way, because
it sounds like you've been comprehensive with him.
Thank you.
Dr. Razia, is there anything about like, as you said, it is biopsychosocial, it is more multidisciplinary, from the biological aspect about the lifestyle, like mostly about, for example, diet or any other supplements can take part here?
I personally believe a lot in a lot of sort of supplement. I've done herbal courses, remedies, herbal remedies. I personally would use those. I have to be really careful because, when you're working in an organization, you have to be careful what advice you give people about herbal remedies. But like, for example, I'll give you an example of somebody who I was talking to the other day, and he was saying that his knees sort of like really locking, and he's scared that, his joints aren't working very well. And I suggested that doesn't he get some supplements for his joints and vitamin D supplements? So I would offer stuff like that. But I think you just have to be careful because a lot of organizations that like in the UK, if you work for organizations, it can be, if something went wrong, they took a supplement that maybe interacted with a medication that they're taking, and then they say, oh, the psychologist told me to take it. It can be a bit, sort of, it could be a lawsuit against you. But I personally believe in using supplements as well in a holistic way. So if I really feel somebody's going to benefit from them, I say to them, why don't you go and see a herbalist? Or why don't you go and ask your doctor to refer you to a nutritionist? Because I don't want to take the risk of saying it myself, even though I think my knowledge of herbalism is pretty good because I've been studying over the years on the use of herbal remedies, but I don't want to take that risk. So if I really think they will benefit, but I don't discount it by any means. I do think it's important. And there is, when we do the pain management program, the group therapy, we have a module where we talk about diet as well. We talk about diet, lifestyle, and a bit like you do with diabetes. And we do mention that what foods are good for pain and what might help. So we're not talking about supplements, but we're talking more about food, which is more respectable and acceptable. But when it comes to supplements, I try to be very, very careful that I don't set myself up for getting into trouble. But I would always suggest to people, if I felt that this person could, I'll give an example. I had a lady who came to see me, and she was depressed actually. And I knew I had a herbalist who worked in the same building as me. And I knew that there was something not right there, and I felt that her having a consultation with him would help. So then I just suggested to her, have you ever thought that there might be something, you know, organic going on, and why don't you see our herbalist? I told her that I don't get any discount if I refer you or anything, but you know, go and see him. And she did, and she actually he found stuff in her blood that showed that there was something not quite right, and he put her on some herbal stuff, and it actually changed her mood significantly. Her depressed state changed significantly. So I do believe in stuff like that, but I'm just very careful in how I prescribe it.
Yeah, of course, like here we have to put it in the right place, let's say, because even, for example, for a psychological aspect, many people say, okay, your problem is as you said in the beginning, in your mind. So they avoid to go for the physician to search if there's anything like biological or organic. They just focus, okay, to avoid it or ignore it. So the misuse for the terms or the advice. Diet is one essential aspect, I believe, especially, for example, chronic disease, diabetes, for example, but it is never replaced the other medical intervention or the psychological intervention. Like, it is one part, and it should be like under the supervision of specialists by more like evidence-based, not just opinions.
Yes,
exactly. So there's many things, and should be also in the right limitations. I found many cases, like, for example, when I was dealing with COVID cases, I had many patients suffering from shortness of breath, but no hypoxia. Then I found that they were drinking daily 2 liters of water with lime. So they had esophagitis, inflammation of the esophagus because of lot of acid. So so it is like lime is good, lemon is good, something with the vitamin C, but misuse,
but not excessively.
To take 2 liters per day, it will harm you, then like have the advantage. So the misuse of lot of herbs, especially with anxiety.
Absolutely.
So, So,
but I've also found that people with fibromyalgia, that lifestyle changes and diet makes a huge difference to their chronic pain. So I won't prescribe anything myself or suggest anything, but I ask them to go and see a nutritionist and get some advice, and because a nutritionist would find out what they're doing at the moment, and then if it was contraindicative, then they would help them develop a plan of what they should do to improve their sort of pain. And quite a few fibromyalgia sufferers had been to see a nutritionist and dietitian, and they said that it's made a huge difference in how they manage their pain. So you're right that, you know, it's an important element of a holistic. If you're talking about a holistic approach, it is important, and I always do consider it. And it's like people with depression. I found out that several patients of mine used to have vegetable patches, and there was a lot of toxic waste in those vegetable patches. So I think it was aluminium or something, and it was affecting their causing neurological symptoms in them. And then I asked them to go and have blood tests done, and through that they found out that they had aluminium poisoning.
Even many studies like find there's a link or possible link between magnesium deficiency and depression.
Yes, and depression, yes.
And they found even magnesium supplements like cause enhancement in many depressed cases. Microbiome or microbiotics, maybe Sabrina may say something here, if you will ask Dr. Sabrina. Like, you have many studies about this topic, and if you have anything related.
Yes, actually, I spent half a year doing studies in Cork at the APC Microbiome Institute, and we were particularly interested in how the gut microbiome could interfere with brain functions via the gut-brain axis. And what we know so far is that, for example, if you're giving probiotic supplements, that it could enhance as well how the way antidepressants work. So you can put it in as an add-on therapy, and it may have some effects. But of course, it's like a very new branch of science, and right now we do not really know how long you should give probiotics, which ones are suitable, or if you and also, you know, because the psychotropic medication you give, for example, if you're prescribing an SSRI or a TCA, then it also interferes with the gut microbiome, so it has like an antibiotic action. And therefore, yeah, there are many open questions still to answer. But right now we are doing a study and having a look at how probiotics could work on the gut-brain axis. We are measuring heart rate variability and to see whether probiotics could have an influence on the vagal nerve function. And I'm really curious about the results, but we are just, you know, we will need a few more months to answer this question.
Yeah, great.
That's really exciting research, and I actually have a huge sort of belief in using probiotics. Because, like, for example, if you take a course of antibiotics, I will always take, for myself, I will always take probiotics to sort of like help balance the gut. And there are a lot of studies, as Dr. Sabrina says, that there are a lot of studies coming out now on the gut-brain sort of link, and I think it is important. I tend to prescribe a lot of herbal remedies to my family, not so much to patients. You know, so I live on herbal remedies myself.
Yeah. Even like some ways which is more safe, even this work like to what call to prebiotic, which is like more veggies, vegetables, fruits. So it is non-prescription, just recommend the client or patient to eat more veggies. So it's safe anyway. So
yeah, that's safe. I think where food is concerned, it's safe. And it's like you mentioned about the research showing that magnesium deficiency can cause depression. I actually tell people to eat magnesium-rich foods, but I'm reluctant to tell them to take the supplements just in case they overtake them, because then it can cause toxicity. And so, but I will recommend magnesium-rich foods, and I would say to them, have you thought about this, because research is showing this, and then put the seed in their head, and if they want to do that, then they do it.
Yeah, and it had many advantages. One of it, when the client or patient focus on this aspect, focus on their lifestyle, focus on their diet, they will start to live the moment.
Exactly. And it's the holistic approach, isn't it? That's where holistic therapies work better, because you're taking every aspect of their life into account, not just you are a patient, you are a depressed person, or this is an organic problem. I think it's really important to take a 360-degree view of their condition.
Yeah, exactly. So if other colleagues have any opinion, comments, question, I think we already took a lot of time from you.
I really enjoyed it, actually. It's quite nice for me to talk about the stuff that I'm doing. So it's been good for me as well. So thank you for attending, everybody.
Yeah. And thanks for you, Dr. Razina, for your time. Although it is last day deal.
If you need me to send the slides, I can do that. If Zubair, do you want them?
Yes, please, and I'll put them into the group. And just once again, thank you for such an informative talk, and I think talk on ACT as well, because I think the group got a bit bored with CBT all the time. So, you know, alhamdulillah, and I think for the professionals in the group as well, it's been very, very informative. Just working in a MDT kind of holistic way has been fantastic.
Just a point of interest, I've wrote, my colleague and I have wrote a book chapter in a book that should be coming out this month, I think. It's called Inequalities in the Health of Muslims. I'll send you the details, and we've wrote exactly what I've talked about, a book chapter on applying ACT to pain management. So if anybody's interested, they can always have a look at that.
Yeah,
most definitely, that would be really useful to share as well.
Share it with you.
And I believe we need some skill-based sessions that maybe depend on your time, like for example for ACT, to have some skill-based sessions, although it is not used to be online, but I think we can try something.
Yeah, we could do.
Yeah.
Just let me know. But don't give me the night before notice.
No, inshallah, that would be yeah, plenty of more notice. We're roping you in now.
If you want something like that, give me a bit of notice, and then I'll also put something together like a workshopy type of.
No, it's
Yes, inshallah, that would
it's
be
easy. I can ask you now for next Monday.
Not next Monday.
Like as it is already connected. Like just.
More like next month.
inshallah soon.
Inshallah. So then we'll see. Like we'll stay in touch and we'll find a good day. I will give you like how many days you need.
I've got quite a lot of stuff going on for the next few weeks, so definitely I'd need at least 2 weeks notice.
Okay.